I'd like to take a moment to welcome you to this virtual learning collaborative focused on focused on improving care for developmental disabilities and dysmorphic features, brought to you by the Midwest Genetics Network at MPHI in partnership with the Minnesota chapter of the American Academy of Pediatrics and the Minnesota Medical Association. The Midwest Genetics Network is a 7-state network funded by the Health Resources and Services Administration that is focused on improving access to genetic services for medically underserved individuals. This continuing education and quality improvement project is one of many resources developed by the Midwest Genetics Network's Stakeholder Education and Engagement Working Group. Today's presentation is the third presentation in a 4-part webinar series. And if you happen to miss the first or the second one, you actually can catch up on what you missed. We have recorded versions of these available on Midwest Genetics Network's virtual learning collaborative channel. And we can put the link to that in the chat box for you in case you don't have it. Right now, there are over 60 providers participating in this particular project from at least 10 different states around the country. So we're really excited to have such a broad reach and have you all joining in this project with us. There's just a couple housekeeping items that we want to go over quick before we get started. First of all, if you happen to have joined the meeting today only by phone, we don't know who you are. The only information we have is your phone number. And so if that is the case for you, if you wouldn't mind sending an email to Danielle and just letting her know your phone number and who you are so we can make note that you are attending, that would be really helpful. We can put Danielle's email address in the chat. I guess that doesn't help you if you're on the phone. So maybe don't worry about doing that part. And then also, if you have colleagues that would like to attend these presentations or participate in the project to get MOC2 credit, MOC4 credit, or CME credit, we ask that you please do not share your particular Zoom link to get to these meetings. We need to track information about who's participating and some other information that we collect in registration for our funder. And that's how we're able to offer these opportunities at no cost. So if you have colleagues that want to participate, please feel free to refer them to Danielle, or even if you have it still, you're welcome to refer them directly to the registration link. Either one would be great. And then finally, for those of you that are participating in this project in order to earn some MOC4 credits, we'd like to ask that any of you who are willing to share in the chat interventions that you've tried in your clinic to improve rates of screening or referral for developmental disability and dysmorphic features, along with any particular successes or maybe even any particular challenges or unforeseen barriers that you may have encountered so far in your quality improvement efforts. So if you'd be willing to share that in the chat with us, that would be really great. We'd like to know how that's going for you, and also other people on the call might enjoy seeing those things and maybe even be willing to engage some conversation with you as well. So with that, I'd like to introduce our speaker today, Dr. Sue Berry. Dr. Berry is a professor of pediatrics and genetics, cell biology, and development at the University of Minnesota, and is the director of the Division of Genetics and Metabolism in the Department of Pediatrics. She received her BA in biochemistry from Rice University and her MD from Kansas University. Dr. Berry completed a residency in pediatrics in 1981, fellowship in medical genetics in 1984, both at the University of Minnesota, and has been on the faculty there ever since then. Like many genetics professionals, she sees adults and children with heritable conditions of all different kinds, and she has a particular interest in providing management for persons with inborn errors of metabolism. She has a longstanding interest in improvement of their care through early diagnosis and treatment. Her research has focused on evaluation of long-term outcomes after newborn blood spot screening. Now, in addition to her clinical practice and research efforts, Dr. Berry has a strong record of service, and we don't have time to fully list all of Dr. Berry's service, but we'll just highlight a few for you. Dr. Berry is a fellow of the American Academy of Pediatrics, a founding fellow of the American College of Medical Genetics and Genomics. She's a member of the board of directors for multiple organizations, including Society for Inherited Metabolic Disorders, for NORD, which is the National Organization for Rare Disease. She's the co-chair of the steering committee for the Newborn Screening Translational Research Network, or NBSTRN. She's a member of the Minnesota Department of Health Newborn Screening Advisory Committee. And she's also a past member of the Federal Advisory Committee on Heritable Disorders in Newborns and Children. Now, Dr. Berry is a founding member and also the co-director of the Midwest Genetics Network. And she's been providing leadership to the network ever since its inception in 2004. And so we're really grateful for her work there. And for those of you that may not know this, Dr. Berry was actually a key part of how I got hired at MPHI and eventually got involved in this work. So I'm very grateful to her for that opportunity. So without further ado, I would like to offer the microphone up to Dr. Berry.
Oh, gosh, thanks, Matt. That was a very generous introduction. I appreciate it. So today, what I'm hoping we can do is help you to trust your eyes. Use your observation skills to be able to discern when something doesn't look right to you and what the implications of that might be. So I'm going to go through some clues and some strategies about the way that we do this kind of observation that may prompt you to say, this child needs more evaluation and maybe needs to go see genetics. So next slide, please. So we want to help you realize that measurements can be really helpful in thinking about how to look at kids. We want you to think about the observation skills that you already have and to describe those findings accurately so that you can assist the person that you're referring to. And we want you to understand how communicating about these unusual physical findings can really make a difference in how syndromes are diagnosed. Next slide. All right, so what I want you all to do as you are thinking about that and as you see children is to trust your eyes. You see what's familiar and you recognize patterns, so you recognize differences. You observe proportions, and these are things that are sort of hardwired into what you see in a face, and when it's different, you know it. So the key to this is describing this accurately and to use familiar words as you need to be able to convey what you're seeing. Next slide. Okay, so this is an example of some of the kinds of measurements we might do, for example. This demonstrates the one marked B would be the inner canthal distance. The one marked C would be the inner pupillary distance. The one marked A would be the outer canthal distance. I would say we don't really measure the lip length too much, but it's possible to do, and there are norms for all of these things. It also tells you to observe. For example, when I started looking at this little picture, I realized that the eyes aren't symmetric. So there's always opportunities for observation. Next slide, please. And what this tells you is that there are growth charts for almost everything. This one shows you the outer orbital distance, which I don't measure very often, but we do measure the inner canthal distance quite frequently. One thing to observe from this growth chart is that the distance between the eyes doesn't change very much once somebody's about 8 years old. Only a very small degree of change takes place after that. So the face proportions that you expect to see in a early adolescent are going to be pretty stable through adulthood. Next slide. So we measure all sorts of things. This one is one of my favorite ones because it's the middle finger as percent of total hand. And the reason I like it is because it's something that doesn't change virtually through any age. So the 50th percentile stays right at 42.5%. So I round that to 43 because it's easier to remember, and you get to be a wizard when you are doing a cocktail party saying, I can pretty much predict what size the middle finger is of your percent of your total hand because it's going to be 43%. We can measure lots of things. They're age related. This happens to be one that doesn't change a lot through time. Next slide. So minor anomalies are a part of the clues that we use to be able to describe something as unusual in physical characteristics, but they're very common. The number that I found in this particular citation was that up to 15% of newborns have a minor anomaly. It may be even more than that. That if you have more than one anomaly, that's a little less common, but when you start adding up more than 3, there's a correlation with the potential for having a syndrome diagnosis and with additional major anomalies. It tells you that something went wrong with the programming in early development, and it means pay more attention. Next slide. So we're going to talk about these in a little bit in terms of the organization of the face. So I'm going to start with the eyes. I'm going to talk about your orbital position, a little bit about the iris, the alignment of the eye, and the configuration of the canthus or the corner of the eye. Next slide. So this is a fairly elaborate chart that demonstrates the organization of the face. And what I want you to take a look at is, and very subtly on the very top picture of this child's face, you can see there's an eye sitting between the 2 eyes. And what that tells you is the distance between the eyes is almost always about the same as the palpebral fissure width. So you have this visual impression when you look at a face of a 1/3, 1/3, 1/3 proportionality between the eyes and the bridge of the nose. When that varies, you recognize it, you notice it. And that can occur for a number of reasons. It can occur because there's extra skin in the corners of the eye. So it looks like the eyes are more widely spaced, but if you look at the distance between the pupils, comparing the top one and the second one, you can see that the interpupillary distance there is unchanged. That means that the eyes are normally positioned on the head, but there's extra skin between the eyes, and that's usually sometimes referred to as telecanthus. In contrast, in the third one down, if you look at the difference between the distance between the pupils, you'll see that they have moved apart. The orbits are moved apart on the head, and so the distance between the eyes looks wider, and it's because, in this case, there's true hypertelorism, what we refer to as hypertelorism. The orbital distance is more separated. This gives an unusual proportionality to the face. Sometimes you will see this when you look at, seems to be a trait that's not uncommonly seen, for example, in fashion models, to have slightly hyperteloric eyes. It gives this face a very open look, and so it's somehow viewed as attractive in that context. If you have epicanthal folds or telecanthus and hypertelorism, you'll have the appearance of very widely spaced eyes because you'll have increased skin between the eyes and orbital distant movement. Next slide. So this is an example of a child who has both true hypertelorism and who has telecanthus, a little bit of extra tissue at the corner of the eye. This happens to be a child with a chromosome abnormality, Crudy-Schott syndrome. The purpose of this is not to help you memorize faces of syndromes. It's to identify the unusual features in the face. And I think that most of you, if you looked at this baby, would recognize that there's a very wide space between his eyes, and you'd say, that's different. I should be paying more attention to that. Next slide. This, in contrast, is a baby that has a very abbreviated intraorbital distance. And this has significantly impacted the entire mid-face of the baby. His interpupillary distance is obviously going to be decreased. And the eyes are a little proptotic because the whole mid-face is poorly formed. But the distance between the eyes here is shortened. Next slide. This is an example of a face of a child who has a syndrome. If you measure her interpupillary distance, it's normal, but she has quite obvious additional skin at the corners of the eyes. This is a representation of what we referred to in that diagram as telecanthus. This is a child who happens to have Waardenburg syndrome, where telecanthus is a very common feature. Waardenburg syndrome is the white forelock hearing loss. This child doesn't have a white forelock, but she certainly has other facial characteristics of that condition. But this was to demonstrate telecanthus. Another observable feature on her face is this sort of medial eyebrow flare. So you can see that there are distinctive features that give her face a characteristic look that helps somebody who's familiar with dysmorphic features identify it. But if you were looking at it, the thing you might pick up, because most people look at eyes, they look at faces by looking at the eyes first. You would say those eyes look widely spaced, and when you did your measurements, if you chose to do so, you would say, but they're not widely spaced. There's just a lot of extra skin between the eyes. Next slide. So this is an example of a little boy who is affected with Down syndrome. I did this picture to illustrate how looking at the iris of the eye can occasionally give clues to diagnostic features. If you look at the very outer third of the iris on his right eye, you'll see that there's little white flecks around the corner of the eye. These are sometimes referred to as brush field spots and are very frequently seen in individuals affected with trisomy 21 or Down syndrome. You also see that this particular little boy doesn't have a lot of extra skin at the corners of his eye. He doesn't have a lot of telecanthus, but he does have a very well-developed eye crease that gives his eyes the characteristic shape of an individual affected with this condition. Next slide. This is maybe, I hope it can be appreciated by all of you. This is a little girl with Williams syndrome. And here I'm again demonstrating a physical difference in the iris. The iris stromal muscles in people who have Williams syndrome may develop this specific pattern that is sometimes referred to as stellate. It looks like their iris muscles are forming a star. And so that can be a feature that can occasionally be identified or is often identified in persons affected with Williams syndrome. Another interesting characteristic that is suggestive of a given syndrome. Next slide. So this is a diagram to sort of illustrate what I was talking about in terms of the skin creases and folds around the eye. The top eye is a person of likely Northern European ancestry. The middle eye is a person of East Asian ethnic ancestry, where they have a epicanthal fold that comes extending from the orbital crease over to cover the corner of the eye. This is in contrast to what is sometimes referred to as an epicanthic fold, an alternative form of the fold that can cover the corner of the eye. In the lower diagram, it represents an individual who's affected with Down syndrome or trisomy 21. And you can see that there's some superficial resemblances between the ethnic Asian eye and an individual affected with Down syndrome, but they are different in their physical characteristics and the way the folds form. And so again, these can be very helpful in describing a physical difference in the eye. It is not uncommon for little Northern European babies to have epicanthic folds when they're born, and as the eye grows and the face adjusts and changes, for that to become less obvious with time. Whereas an individual with East Asian background, rarely absent the use of plastic surgery, has a variation that changes very much in terms of their epicanthal fold. Next slide. So this is a little boy who has Down syndrome. You can see that he has bilateral epicanthus. There are other features that help us and you when you recognize, many of you, most of you would recognize an individual affected with Down syndrome. But the reason that you notice them is because they have fairly persisting facial characteristics that include a relatively flat profile, smaller ears, a little bit of upslanting to the palpebral fissures and the epicanthal folds. And so those features taken together form a pattern that your eye recognizes. Next slide. This is a little girl. We'll come back to her later, but she has pretty well developed epicanthal folds, almost to the point where they almost look East Asian in background, although she is not. She's an African American child who has the appearance of her wide space between her eyes exaggerated because she also has strabismus, so crossing of the eyes. But you can see that this variation in epicanthal fold can appear in persons of all ethnic backgrounds and can sometimes be a clue to a characteristic feature that describes a syndrome. So this particular child happens to have Prader-Willi syndrome. Next slide. Excuse me. This is a face I think that anyone of you who were observing the face would recognize as distinctive because she has this unusual iris configuration that's caused by failure to properly have joining of the globe as it forms as a tube and then completes the globe in embryonic life. And when that happens, it usually would fuse at the nasal lower side of the iris. And in this case, what you get instead is this almost keyhole shaped appearance, sometimes referred to as an iris coloboma. This is obviously a major malformation of the eye and can, depending on where the failure of fusion takes place, affect other elements of vision. You can also see, if you're paying close attention, that she has a hearing aid in place. And so she has a syndrome that encompasses those features. Next slide. So I'm going to talk a little bit about ears. I think everybody, when they're, the thing that most people try and figure out is if someone has low set ears. So we're going to go through that specifically. We're also going to describe and remind you that almost everything, it's helpful to have sort of a way to describe features. So we're going to give you some information about names. We're going to talk about the configuration of the ears, and we're going to talk about how the structures can be altered. And I'm going to minimally discuss a little bit of embryology related to that. Next slide. All right, so this is a diagram of an ear, and what it tells you is that there's a name for all these parts of the ear that helps you describe it. I think most people are familiar with the description of the outer curve of the ear as the helix. The inner curve that makes the ear lay flat to the head is the antihelix. And it has a sort of a branching structure at the top. So you have a top part and a bottom part, and a fossa that goes between them. It's triangular shaped, the triangular fossa. The curve or shell of the ear, the concha, is something that's worth being able to describe. And then you have the little bump that's in the front of the ear, the tragus, which sometimes gets pierced. And then you have an opposite little bump on the other side of it called the antitragus. There's the earlobe. And the key here is not necessarily to make everybody memorize all the parts of the ear, but just to be aware that these things have names. And so that when we're trying to characterize an ear and say why something doesn't look right, we have names to give it. For example, if the antihelix doesn't form well, what happens is the ear will tend to have a tendency to look sort of flat and may even be a little bit cupped because the formation of the cartilage didn't take place correctly. That in itself isn't necessarily something wrong, and there are people who have no syndrome features otherwise who have distinctive ears, but we can describe that as a variant from average. Next slide. So this is a diagram stolen from one of my favorite books. It's a very old book, so the pictures aren't in color, but I like it anyway. Because what it does is it shows that you really need, when you're trying to observe the position of the ear, you need to have the head aligned straight up. If you tip it back, you're going to be misled. The way that you can do this, and I'll show you this on subsequent slides, is to draw mental lines between the inner corners of the eye and extend them to horizontally along the back of the head. what you'll see is that even in a normal head with normal positioning, the ear is slightly tipped back when you compare the bottom of the base of the lobe to the top of the helix. And so there's a little bit of angle on that. If you tip your head back, it exaggerates that. It makes it even look like the ear is low set. So you have to make sure you position the head correctly, or you're looking at it straight on if you're trying to estimate if an ear is low set. Next slide. This is another way to do that. That some people find helpful, so I'm showing it partly for that and partly to demonstrate this angularity. If you draw a line from the corner of the eye to the point of the skull when it curves in, the occipital protuberance, the top of the ear should be probably at least close to a third of the ear will be above that line. You also see that this diagrams nicely that angle, if you draw a vertical line and then draw an angle between the top of the helix and the base of the earlobe, it's about 20 degrees, 15, 20 degrees. That's a normal degree of posterior rotation of the ear. If it's greater than that, though, the ear is defined as posteriorly rotated. If the ear is below that horizontal line, that quasi-horizontal line that's described on this one, or also that you can draw mentally between the canthi, that may demonstrate that the ear is low set if it fits below those lines. Next slide. So here's a graphic example of where they've drawn the picture on the slide, where the outer corner of the inner canthus of this one happens to be demonstrated with an intercanthal line. So you can see that almost all of the ear fits below that line, in part because it's posteriorly rotated as well. That angle is a good 35, 40 degrees. So this is a baby that has a low set, posteriorly rotated ear. You can also see, incidentally, that the antihelix isn't very well formed, so the ear looks sort of simple or flat. Happens to be a child with a chromosome abnormality. Next slide. So the ear is actually made up embryologically of 6 hillocks that gradually rotate and form together. So you can predict, if you have an ear that's malformed, what parts it came from. For example, the tragus came from the first hillock, where the antitragus comes from the 6th hillock. Most of the antihelix comes from hillocks 4 and 5, and the helix itself comes from helix 2 and 3. Next slide. So if something goes awry in the formation, it's a little hard in this ear, which has significant malformation, to just demonstrate what that remnant, that piece is. I think it's probably a part of the original lobe and antitragus, but it's a little hard to tell. But obviously this ear is significantly malformed. There was an embryologic disturbance in the formation of that ear. This does not necessarily predict the degree to which the inner ear or ossicles are impacted. So sometimes kids like this, who have very normal outer ears, will have significant hearing capabilities because the inner ear is less affected. Next slide. Here's an example of a gentleman who actually has what is sometimes referred to as anotia. You can see the remnant of the external auditory meatus. There's the hole that would go back into the ears there, but there's essentially no other ear formation. You can also see how much the normal ear formation impacts the hair patterning, which is quite different in this individual. He had relatively limited hearing because this particular malformation also impacted his inner ear formation as well. Next slide. All right, I'm going to mention ear tags because they're really common. Somewhere between 1% and 2% of individuals will have an ear tag. They're usually asymmetric, so you usually may have it on just one side, for example. And if they're well enough developed that they have a cartilaginous base, then they have to be removed surgically. If it's just a little skin tag, some people will correct those by tying a suture on it, and it'll essentially fall off. Next slide. So here's a relatively exaggerated example of ear tags. Again, they tend to be anterior. The most common shape or formation of the ear tag is this one at the base of the helix, but they can occur anywhere along the cheek and face. Again, in this particular picture, the ear tags that are present here would likely require surgical removal. You have to be careful that there are not other embryologic remnants associated with them, such as sinuses or tracts, because those are subject to infection. So you have to look carefully when you do a procedure to remove these. Next slide. So I'm going to mention preauricular pits. They're a lot more often seen in persons of color than persons of Northern European extraction, but they're present pan-ethnically, more common in females than males. Mostly they're uncomplicated, but you can, again, these typically represent a little minor error in embryologic formation, so there may be a tract or sinus behind them. Now, of course, like anything else, as a minor anomaly, they can be an aspect of a syndrome. Next slide. And this one, oh, my arrow moved. Oh, I don't know why. It's not referring to the ear. The actual location of this, it's right at the base of the helix and you can hardly see it. Danielle, do you have the arrow? I'm sorry, I tried to move the arrow and I moved it badly when I revised the slide. It's okay. It's okay. Don't make a big deal of it. Just move it up a little bit. It's right at the base of the helix. It's okay. There it is. Yep. It's a little tiny dot in the bottom. That's the usual location. Occasionally you'll find these because they drain, because there's a cyst behind them. So, but they can be seen as a minor anomaly or as part of a syndrome. Thanks for doing that, Danielle. Next slide. All right, we're going to talk about the nose. Like other characteristics, there are names for these, but I think the thing that most people end up saying, I see the faces on you, I think there's something different about the nasal bridge. We're going to talk a little bit about that. Next slide. I like this picture because it shows you how different noses can be. Each one of these is normal. This is a shot taken from below, showing the nasal columella. And you can see there's wide variation in the density of the nasal tip, in the shape of the nostrils, in the extension of the nose from the face. All normal characteristics. One of the things that gives faces beauties is their wide variation. Next slide. And so like we described for ears, it's sometimes helpful to be able to describe elements of the nose. So the portion right between the eyebrows is sometimes referred to as the glabella. The point at which the nose meets the skull, the nasal cartilage is sometimes referred to as the nasion. Most of you are familiar with the philtrum, but the tissue that attaches the nose to the tip of the base of the nose to the tip of the nose is the columella. We look at the alar wings, the nasal wings. We sometimes will have variations in the crease at the corner of the nose, the supraalar crease. So knowing names can help define what you're seeing. Next slide. All right, this is a characteristic that I think many people identify as giving a face a distinctive character that can be associated with the syndrome, and that is the degree of what we call a nasal bridge. How high is the nasal bridge? That's primarily defined by how far the skull extends out from the plane of the face. If it's shorter and less angulated, you'll have a low nasal bridge. And the main structure that you'll see in profile is a little bit more curvature and less space between the corner of the surface of the eye, and the whole profile becomes flatter. Next slide. So here's an example of a child who has a low nasal bridge. He also has epicanthal folds, so it gives his face a very distinctive appearance. Next slide. This is a child who, despite having the most gorgeous red hair possible, I put in the picture because she has a high nasal bridge. This is characteristic of the chromosome abnormality that she happens to have, which I'll mention, but I'm not trying to do it because I want you to memorize. It's 1p36 microdeletion syndrome. But the individuals affected with that have the appearance of having somewhat deep-set eyes, in part because they have a high nasal bridge. Next slide. This is, I mentioned earlier that when you look at faces, a lot of us look at eyes, and that often is the characteristic that helps us define the pattern. In this particular condition, the nose is a distinctive feature of the individual that's impacted. They have small alar wings. They have a broad nasal tip that is sometimes referred to as bulbous, and a relatively flat mid-face, less well-developed cheekbones. So the face is a very distinctive one, in part because of the characterization of the mid-face and nose. So this happens to be an individual who has a condition that's called trichorhinophalangeal syndrome. Tricho because they have usually thin hair. Rhino because they have a distinctive nose, and phalangeal, if you saw their hands, you would see that there are distinctive features associated with this condition. But the nose is the key in this one. Next slide. So I'm going to talk about the mouth and oral structures. There's a wide variation of normal once again for this. We're going to talk a little bit about lip character, size, and clefting of the mouth. And next slide. So this is an example of an individual who is affected with cleft palate. You can see that this is one-sided, and he does not have a cleft lip. Even at this angle, I think you can also see that his face has a distinctive characteristic. He has very poorly formed cheekbones, and probably if you tipped him up, you would recognize as he has unusually shaped eyes. This happens to be an individual affected with Treacher-Collins syndrome, but this is an example of a cleft palate without a cleft lip. Next slide. This is a characteristic shape of a mouth in an individual who has facial weakness. Sometimes describe it as a tent-shaped mouth. You can see that the bottom lip is nearly horizontal and that the peak of the upper lip has almost a triangular shape. And so you can also see, if you look closely at the picture, there's some drooling. It's because this child has facial weakness. This is a mouth that's very characteristic in a child, for example, that's affected with congenital myotonic dystrophy. Other forms of facial weakness can give a similar appearance, but this is defined because of facial muscle weakness. Next slide. This is a wide mouth, and this is an individual affected with Williams syndrome. He also has relatively small and relatively widely spaced teeth, which make his mouth look even bigger. In adolescence, this physical feature becomes more prominent in a person affected with this condition. Next slide. So we're going to talk a little bit about the extremities. We're going to talk about their configuration, their symmetry, extra digits, and a little bit about muscle mass. Next slide. So one of the advantages to the extremities is you have the other one to compare to. This mama brought her little one in saying she thought his right arm was too big. But when she raised his arm up, it became evident that it was that his left arm was too small. You can see that line of tissue that comes across over the top of his nipple is the remnant of his pectoral muscle. So he's had a vascular variation that resulted in poor growth of his left arm, sometimes referred to as Poland anomaly. This causes also asymmetry of the mid-chest. So you can see one of his nipples is a little better formed than the other. This impacts, obviously, if a female has this, she may have asymmetric breast development. But it's a matter of sometimes being able to tell which one's too small and which one's too large. In this case, the left arm's too small. Next slide. So this is a child who's affected with a clinical condition where the clavicles didn't form well. The reason you can oppose his shoulders nearly to the center there is because he doesn't have any collarbones. He has a big red mark on his head because that's demonstrating his open fontanelle. So this is a child who has a disorder referred to as cleidocraniodysaustosis. It's a specific genetic condition that has this cluster of physical differences that allow us to identify it quite readily. Next slide. And to demonstrate that the physical characteristics are also generally pan-ethnic, this is a little boy where the reason his forehead shines, or you catch the shine on his forehead as much as you do, is because he has the same very poorly formed skull with wide open fontanelle at a much too late age. He has bilateral epicanthus, and he also can move his shoulders to the center. So one of the things that is and remains a challenge is that the learning tools that geneticists have not properly represented persons of all ethnic backgrounds. That's something that people are working hard to change. But that being said, in many cases, the characteristic elements of a syndrome remain quite recognizable despite the ethnic background of an individual. Next slide. Excuse me. This is to demonstrate the lymphedema that can sometimes be seen in a syndrome or in disorders of lymphatic formation. So this puffy little hand is present on a girl that has Turner syndrome, one of the conditions where distal lymphedema is a common feature. Next slide. This is her little foot. She almost has a boggy appearance to the posterior aspect of her calf, and a lot of fullness and bogginess of that foot. So lymphedema associated with either lymphatic malformations, Turner syndrome, or Noonan syndrome. Next slide. This is a generally acquired abnormality, less seen now than previously. This happens to be the hand of a young adult who had Hurler syndrome, where there's gradual accumulation of mucopolysaccharide ground substance that it results in contracture formation in the hand. Most children with that disorder are identified by newborn screening and have less physical impact with time than they would untreated. But this is an acquired malformation of the hand due to accumulation of glycosaminoglycans. Next slide. This is to illustrate hypermobility. This actually was one of our residents who showed us this when we were discussing hypermobility as a feature in certain syndromes. And she said, "Do you mean like this?" We said, yeah. Obviously, this is not the usual finger that we look at for this. We tend to, the standard characterization of this has to do with mobility of the fifth finger, and I'll go through that in more detail. But persons who have significant joint hypermobility can do this kind of a maneuver without specific discomfort or pain. Next slide. Another characteristic of some individuals who have joint hypermobility can be changes in the skin. We were seeing a child that was sent to us for hypermobility, was sent for hypertonia, floppy muscles, and it became clear that what she had was floppy joints. And she had unusually textured skin, and I said, "Gee, it looks a little stretchy," and the dad leaned over and says, "You mean like this?" And so this is an example of the hypermobile or stretchy skin you'll see in classic Ehlers-Danlos syndrome. I want to make the distinction. It's really easy to hear Ehlers-Danlos syndrome and just think it's all one thing, and it's not. So persons with classic Ehlers-Danlos syndrome will typically have fragile skin, poorly healing scars. They may have joint hypermobility as well, but their skin characteristics, I think, dominate their clinical picture more than their joint ones do. Next slide. In contrast, and I'm sorry, this is small, so we can make this visible and available if people want to see it. Persons who have what is commonly referred to as Ehlers-Danlos of the hypermobility type will have a more relatively normal skin, but may have very specific abnormalities in joint mobility. And so there are maneuvers that you can perform that will help you define the degree of hypermobility. The thumb to wrist, the extension, it's best done if you put the hand flat on the table and then extend the fifth finger up. If it's greater than 90 degrees, it counts. And you get points for each side. So the thumb to wrist, the finger, hyperextension of the elbows, best demonstrated using an angle or goniometer. Hyperextension of the knees in a standing position, again, a point for each side. So the ones in the top are 4 points. You get a ninth point of the total 9-point score if the individual can place their palms on the floor without bending their knees. So an individual who has a hypermobility score greater than 6 is regarded as having significant joint hypermobility. Next slide. This is to demonstrate what is sometimes referred to as the Steinberg thumb sign in an individual who has long bones and a little bit of hypermobility. If you make a fist, the thumb will stick out this way because the thumb is long and the thumb joint is more flexible. This is sometimes seen in individuals affected with Marfan syndrome. The other corresponding one is to take the baby finger and the thumb and wrap it around the wrist, and if the joints overlap, that's again evidence of long bones. Remember that middle finger is a percent total hand. Here's a place where the middle finger will be a higher percent of the total hand. If it's significantly increased, it also demonstrates long bone overgrowth, again associated sometimes with individuals affected with Marfan syndrome. Next slide. Syndactyly or fusion of the fingers or toes happens relatively commonly, 1 in 2,000 births, more common in males. The most common is webbing of toes 2 and 3, that is the toes next to the big toe. Many people think that is a normal variant because it's so common. It's often familial. It can be seen in syndromes. If it's not toes 2 and 3, if it's other fingers or toes, more likely to be syndromic. Next slide. So here's an example of the syndactyly of toes 2 and 3. This is pretty well developed. It goes all the way to the base of the toenails. In contrast, here's a hand where you have fingers 3 and 4 fused. That would require operative reduction. Depending on the structures of the bones underneath, the fingers could likely be released. Next slide. Then I want to mention polydactyly. This usually means 6 fingers, and it's most often a 6th finger or baby finger side or post-axial. It's often familial. It can be seen as part of syndromes also. Next slide. So here's an example of a hand with that 6th finger. This one's pretty well developed. This happens to be a baby who had trisomy 13. So you can see he has deep set and hyperconvex nails as well, but he has the 6, he or she, I don't know which sex this individual is. This person has a 6th finger hexadactyly. Next slide. Here is an example of so-called pre-axial or large finger side, like the thumb side or big toe side, polydactyly. The foot on the left there has, you can see there's almost a divot between the two, between the great toenail. There's a duplicated hallux or a duplicated great toe there. The other toe is quite broad, but it's not as obviously duplicated. But this is almost always when you have pre-axial or thumb or big toe side, it's almost always syndromic. Next slide. A single transfer palmar crease is something that's often identified. It usually means you have short metacarpals or a short palm. It's very common to see in either unilateral or bilateral in persons who are neurotypical and who have no other syndromic features, more common in males than females. Reflects very early embryonic development. Next slide. So here's an example of an individual who has a single transverse palmar crease. I think most people, when they're thinking of a single transverse palmar crease, though, associated that with a common feature in trisomy 21. And so this is a very good example of that in an affected individual. Next slide. Clubfoot is a relatively common minor birth defect. It's often due to in utero constraint and is therefore sometimes referred to as a deformation. There is some degree of familial predisposition, but it's not typically simple genetics. Most of the time, because it's just a deformation, conservative treatment with casting or taping can take place, but about half of them will require surgical intervention to straighten the foot. Next slide. So here's an example of bilateral club feet. And again, if you passively and gently stretch that foot and you can bring it into a neutral position, the foot is highly likely to be amenable to conservative management. Next slide. I wish this was a better focus and I apologize, but this is a baby's knee and has this large divot in it. Next slide. And this is her dad's knee. You can see that there's this unusual tendon coming across where a kneecap should be. He doesn't have much of a kneecap and he has that same divot in his knee. Next slide. And he has very abnormal fingernails. So this is an individual who's affected with nail patella syndrome, whose daughter has inherited that genetic condition. Next slide. I'm going to talk a little bit about appendages, skin, hair, teeth, and nails. These are all ectodermal derivatives. So if you have one appendage that goes wrong, then you often have another. There's often patterns of these abnormalities. I'm going to demonstrate those. Next slide. Skin abnormalities often fit into sort of linear distributions, and it can be a little difficult to tell them apart. They can be along dermatome distribution, that is the exit of the nerves from the spinal column and cranial nerves, or they can follow the stretch lines of the ectoderm as it spreads across during embryonic formation. These form a similar sort of swirly pattern, also sort of linear, but they're not defined by nervous distribution, but by the growth of the skin. Next slide. This is an example of a child with skin pigmentation along the lines of Blaschko. Next slide. And this is a little one who has facial angioma in the distribution of the dermatome, in this case V2. So you can see that it matches that innervation pattern from the cranial nerve of the trigeminal. Next slide. This is an example of an individual who has ichthyosis or altered skin pattern. This may be at birth a collodion or almost a film-like covering of the skin, but gradually reduces to this. Requires a lot of attention to maintain skin integrity. Next slide. And this is our little friend from the earlier slide with bilateral exaggerated epicanthus and almond-shaped eyes. I brought this back, though, because this demonstrates that some individuals with Prader-Willi syndrome have a deletion in the chromosome that impacts the formation of pigment. And so their particular form of Prader-Willi is often associated with hypopigmentation. And so this little child of African-American ancestry has skin that's much lighter in character than either of her parents. Next slide. This doesn't show up as well as I would like, but scattered on this young man's skin are lightly pigmented spots of cafe au lait character. They're referred to, coffee with cream. This is typical in individuals who are affected with neurofibromatosis, a very common genetic condition. If you have more than 3 cafe au lait spots, the chances that you may have neurofibromatosis is quite high, and it merits further evaluation. Next slide. This little one has what is referred to as kinky hair. He has a disorder of copper metabolism that results in hair fragility. The technical term for his disorder is Menkes syndrome, a disorder of copper transport. But he has fragile, broken off eyelashes, eyebrows, and hair. Next slide. This is to show a low hairline when there is a cystic hygroma and extension of lymphatic tissue in early fetal life that happens in a number of disorders. It stretches the forming hairline and it brings it down further on the neck. So this is a low hairline for an individual that's affected with a syndrome. Next slide. This is the front of his face. He has Noonan syndrome. You can see a little bit of webbing to the neck, and that's caused by excessive lymphatic accumulation in the posterior neck, also sometimes seen in individuals affected with Down syndrome or Turner syndrome. Next slide. This is a little girl who has a disorder in that same related pathway, the RAS pathway. She has cardiofaciocutaneous syndrome, but the key for her is that she has these really glorious curls that were not present in any other family member that are characteristic of this particular condition in persons who often have ethnically straighter hair. Next slide. I did this picture because it shows you the lines of Blaschko on the skull. This child happens to have an altered hair whorl pattern that was quite distinctive. Next slide. And then final, the teeth. This was one of the cases that I observed when I was a fellow, so it's a long time ago. We saw a little girl who had an episode and was presented with seizures and diabetes insipidus and a distinctive face with relatively close set eyes. This is her dad on the lower panel. He had a single central incisor. He said, well, that's just like my sister. She had the same thing. And so we suspected that this represented a variation in mid-face formation that had variable expression. So we counseled the family that we thought that the risk that they'd have another child with some form of similar problem was high, it's probably 50%. This was before we actually had the genetic identification ability for this particular gene, which we subsequently ascertained. Next slide. So the result of the pregnancy in this family the next time was this baby that I showed you before, who has a more severe form of mid-face malformation and a brain abnormality referred to as holoprosencephaly, where the face reflects the brain. He has a special form of cleft palate called premaxillary agenesis. So in this case, the clue for the family in terms of counseling and information that they were at risk was the observation of the single central incisor. So careful examination of all appendages can be extremely helpful. And with that, I think that concludes the lecture part of this. I'm sorry it took a little longer because there's a little lag on the slides. My apologies. But I'd be happy to wait and continue to answer any questions if anybody has them.
Yeah, thank you, Dr. Berry. If you'd like to chime in and ask a question, please feel free to go ahead and unmute and do so. You're also welcome to put any questions you might have in the chat. And if we need to cut this off here in a few minutes and don't finish answering them, we will go ahead and answer the questions either recorded or type them out for you and make sure everybody gets responses.
And Danielle, you can go ahead and close the... so that we can see faces if that's relevant. So.
Sue, one question I had for you as we're waiting to see if anybody else has them. Do you have any advice for primary care providers who maybe observe one of these features, and in terms of how to approach that with the family, like how to start a conversation, how to talk about what a next step would be of maybe going to see a genetics professional, anything like that?
That would be, I think, a really important thing to have maybe mentally prepared. So I think that the most common thing that I've advised is that you share with the family that you're noticing something that's physically different, that everybody is entitled to, and we all have physical differences, but that sometimes those are clues regarding something that needs to be maybe a little bit further evaluated, that it may be just a personal difference, but it may be a sign of something else, and that you'd like to explore it further to make sure that you can provide the best care possible for their child. So I try and de-emphasize the idea that it's abnormal or that it's bad. Obviously, you want to not do that because everyone's entitled to personal differences. We all have them. But if you're recognizing a pattern, it also would not be fair not to mention it to the family and tell them you felt it would deserve further assessment.
All right, so I'm not seeing any specific questions coming in on the chat. Certainly we can hang here for another couple of minutes in case any come, but I think with that, I just want to say thank you to everybody for joining the presentation, and thank you, Dr. Berry, for the great presentation. It was very comprehensive and very informative. And it looks like maybe we just got a question. Let's see.
It's mostly just nice things. Thank you.
Okay, great. Yeah, great. So
here's one. How do you address traits that seem to run in a family but are also indicative of syndrome? Really important, because obviously if somebody has a family trait that they observe, it's a little harder to make a case that it requires evaluation. And I think, once again, you bring something up directly to the family. Say, I noticed that both you and little Billy have this distinctive difference in your hands. And while I see that that's probably a family trait, it may be a clue that there's something else for Timmy's health that we should explore. This could also have impacts for you, so it's maybe best if we check it out. But it is a little harder sometimes when people say, well, everybody in our family has that, and I go, yeah. But I think the fact that it almost makes it in some ways a little bit easier, because one normalizes it to some degree, and also allows them to, when you mention that sometimes people have this problem, this particular physical trait may have this other physical issue, if you've happen to have the opportunity to do that, and they say, oh yeah, that's right, my mom had to have a kidney transplant, everybody was worried about that, and I worry about my kidneys too. And they say, well, here's some place where we could explore that better for you and for your family. So sometimes you end up helping them realize that some of the health issues that they are experiencing could be related and are worthy of further assessment. All right.
I see somebody chatted in, where will we find the recording of the presentation? I think if you have the full chat, we may have put that in the chat already, but we can stick the link in there again here in just a second. And then also, if you don't happen to catch it from the chat, we just send an email to Danielle, and she can make sure you have that link.
To this presentation, I will email everybody out, all of our registrants, the link to where the recordings for all of the Virtual Learning Collaborative presentations are posted. So you can expect that to be seen once we get this recording posted. So just be on the lookout for an email from me. The link will be in there. Or email me directly, whatever you want.
And it does take a little while for the recording to process, so it may not be today. It might be tomorrow.
Zoom recordings.
Yeah. All right. Well, thank you everybody so much for attending, and we'll look forward to maybe seeing you again in about 3 weeks, I think is the fourth and final presentation in this series. So look forward to seeing you then.